Patients with serious mental illness face a severe mortality gap. Even with full psychiatric stability, their life expectancy drops by 15 to 20 years. This premature mortality is not primarily driven by the psychiatric etiology itself. Instead, the leading causes of death are cardiovascular disease, diabetes, and complications stemming from metabolic syndrome. This creates an iatrogenic paradox. The most effective pharmacological treatments available to stabilize a patient's mind are independent, potent drivers of their physical metabolic crisis. Second-generation antipsychotics carry the highest liability for this rapid metabolic disruption, with clozapine and olanzapine presenting the most severe risks in clinical practice. This timeline and corresponding chart illustrate the specific clinical threshold of this side effect. Clinically significant weight gain is defined as a 7% or greater increase in baseline body weight, an effect that frequently occurs within months of initiating these medications. The current standard of care forces a devastating trade-off upon patients. They secure their psychiatric stability, but they pay for it with profound metabolic morbidity. The traditional first-line approach to managing antipsychotic-induced weight gain relies on behavioral and lifestyle modifications, such as dietary counseling and exercise regimens. In this specific patient population, lifestyle modification frequently fails. The biological barriers of negative psychiatric symptoms, like severe avolition, combined with the overwhelming pharmacological drive to eat caused by the medications, make sustained behavioral changes highly improbable. Metformin is often prescribed as an evidence-based adjunctive therapy. However, its primary efficacy lies in the prevention of initial weight gain rather than the substantial reversal of existing severe obesity. The clinical fallout of these limitations is severe. Uncontrolled weight gain becomes a leading cause of medication non-adherence, which predictably triggers psychiatric relapse and hospitalization. Psychiatry urgently requires an evidence-based pharmacological strategy capable of reversing massive metabolic disturbances without compromising the patient's hard-won psychiatric baseline. Glucagon-like peptide-1 receptor agonists offer a targeted solution. Peripherally, these drugs delay gastric emptying, which physically promotes early satiety during meals. Their critical mechanism for psychiatric patients occurs within the central nervous system. These agents cross the blood-brain barrier via circumventricular organs to directly modulate brain pathways. In the brain's hypothalamus, GLP-1 resets the dysregulated satiety threshold. It activates POMC neurons, triggering strong fullness, while inhibiting AGRP and NPY neurons, which stimulate hunger. Conversely, antipsychotics like clozapine and olanzapine block histamine and serotonin receptors, inducing an artificial starvation signal. The GLP-1 mechanism directly overrides this iatrogenic effect. Beyond the hypothalamus, these medications act on the mesolimbic reward system. They enhance GABAergic input to the ventral tegmental area, suppressing dopamine spikes triggered by food cues. These medications biologically silence the intrusive food noise and persistent reward-seeking behaviors iatrogenically induced by antipsychotics. This biological theory translates directly into clinical reality, as demonstrated by randomized trials evaluating GLP-1 receptor agonists in schizophrenia patients. This chart compares weight loss outcomes. In the Larson trial, schizophrenia patients taking liraglutide over 16 weeks dropped 5.3 kilograms in body weight. The 2025 SAS trial showed stronger results. Patients using weekly semaglutide achieved a 9.2 kilogram average weight loss. Compared to metformin's 3.2 kilogram reduction, semaglutide is a stark outlier. The most critical finding for prescribers involves psychiatric stability. Across trials, GLP-1 receptor agonists did not exacerbate psychotic symptoms, maintaining stable PANSS clinical scores. The MOSA Palette study confirms these controlled trial results translate successfully into routine outpatient clinical practice. The data establishes GLP-1 receptor agonists as highly effective tools capable of safely reversing antipsychotic-induced weight gain in the most metabolically vulnerable psychiatric populations. There is growing media coverage suggesting these medications might treat psychiatric symptoms independently of weight loss. We must clearly delineate proven metabolic applications from investigational hype. There is strong biological plausibility for treating substance use disorders. Dampening incentive salience in the brain's reward circuitry extends logically from food to alcohol and drugs. But clinical evidence for treating depression, treating primary anxiety disorders, or cognitive deficits in schizophrenia remains mixed and highly investigational. The professional boundary is clear. Psychiatrists should view GLP-1 receptor agonists today as potent metabolic rescue agents rather than standalone psychotropics. Integrating these medications requires addressing a major clinical controversy. Post-marketing surveillance reports flagged a potential association between GLP-1 use and increased suicidal ideation and depression. This balance scale weighs those observational signals against comprehensive meta-analyses and regulatory reviews by the FDA and EMA, encompassing over 80 randomized controlled trials. The definitive conclusion is there is no causal link or statistically significant increase in psychiatric adverse events compared to placebo. Standard randomized controlled trials frequently exclude patients with severe active suicidality. This leaves a slight evidence gap for highly unstable populations that clinicians must factor into their prescribing logic. The most common adverse events recorded are not psychiatric, but rather mild and transient gastrointestinal issues, specifically nausea and vomiting. While the psychiatric safety profile is robust, standard clinical vigilance remains essential when prescribing any new agent to complex, multi-morbid psychiatric populations. There is a severe physical risk highly specific to the psychiatric integration of GLP-1 medications, the compounding effect on gastrointestinal motility. Clozapine is a highly anticholinergic medication, infamous in psychiatric practice for causing severe constipation and potentially fatal paralytic ileus. Adding a GLP-1 receptor agonist, which intrinsically delays gastric emptying, to a clozapine regimen creates a synergistic risk for life-threatening bowel obstructions. Prescribers must aggressively monitor and prophylactically manage bowel function when combining these two classes of medication. This clinical flowchart outlines the evidence-based treatment escalation algorithm for antipsychotic-induced weight gain. Step 1 is lifestyle modification. Step 2 is metformin for early prevention. Step 3 is the introduction of GLP-1 receptor agonists for significant metabolic reversal in non-responders. Providing access to these medications is a critical issue of clinical justice. Patients with severe mental illness frequently face steep barriers to care, ranging from high out-of-pocket costs to restrictive insurance criteria. Psychiatrists now possess the essential pharmacological tools to ensure that effectively treating psychosis no longer guarantees cardiovascular death. Integrating GLP-1 receptor agonists successfully elevates psychiatric practice into holistic, life-extending medicine.